Good morning, everybody. Today we are going to discuss about VSD, pulmonary atresia, a very complex congenital heart disease, a very rare condition and a variant of tetralogy of Fallot's. Its evaluation and intervention, the possible intervention. We all know the definitive treatment is a surgical method, but what are the palliative interventions that we can offer to our tiny babies sometimes when they come in a moribund state? All those options we are going to see in this presentation. So as we know that tetralogy of Fallot is an extreme, pulmonary atresia TOF is an extreme form of TOF, and it's a rare disease, although because of the high population in India, it's not very rare to us. But overall incidence is 0.7 in 10,000 population according to the Baltimore, Washington study. And it accounts for 1/5 of overall tetralogy patients, that is around 20%. So how these kids present to us? The commonest presentation is most of the time in newborn period when they present with cyanosis and without murmur. So cyanosis without murmur, the most common diagnosis will be VSD pulmonary atresia or transposition of great arteries. So these children sometimes when they are very sick, presents with cyanosis, deep cyanosis, acidosis and shock, then it is likely due to the duct has started closing or it is giving very diminutive flow to the pulmonary circulation. Sometimes they are asymptomatic when there are collaterals already present and that is giving a good supply to the pulmonary arteries, and they present to us in a neonatal period with a murmur. And sometimes they remain asymptomatic because of that. So all these kids who remains asymptomatic with because of the murmur, they can present to us during infantile age, again due to incidental pickup of a murmur, continuous murmur, or minimal cyanosis, or when there is a high flow condition due to large collaterals, they can rarely present in 10% of situation as a congestive cardiac failure as well. Sometimes if PDA persist, then also they will have a good pulmonary circulation, and because of that they remain asymptomatic and minimal cyanosis with that they can present. Rarely infantile cyanosis can be due to cyanotic spell. Sometimes all these kids, those who persist, those who have got collaterals, good size of collateral, they have gone through their infantile age, they can manage to grow up to adulthood, and in adulthood they become very severely cyanosed. They are quite symptomatic with dyspnea on exertion because these collaterals have got tendency to become stenosed over the period of time. So they become very cyanosed, they become polycythemic and hypoxic insult to even ventricles in a form of ventricular dysfunction is seen in all these patients. So adulthood presentation is due to cyanosis, polycythemia, hemoptysis, sometimes these collaterals can rupture, and dyspnea on exertion. And variable age of presentation can be seen depending on if they have got genetic abnormality. So sometimes they remain asymptomatic, that group is very small, but because of genetic abnormality associated like trisomy, Down syndrome, they come to us for cardiac evaluation, and in that it is seen that the patient has got VSD pulmonary atresia condition. So this is a spectrum of disease. We all know that most of them, 50% of them die by 1 year of age, and only few, that is 8% of them manage to grow till adulthood or by 10 years of age. So it is, if it is left untreated, it's a life-threatening condition because of the duct-dependent pulmonary circulation. Now, how will be the ECG? Newborn or an infantile age group, a classical feature of tetralogy of Fallot, that is the early transition from V1 to V2 or V3R to V1 will be seen, along with right axis deviation and deep S waves in V5 and V6. So early transition remains the hallmark, but right ventricular hypertrophy and right axis deviation, which are normal for newborn, will also be seen. If this persists by 3 or 4 years of age, then definitely this again become characteristic of tetralogy of Fallot or VSD pulmonary atresia condition during early childhood period. Once they grow up to adulthood, characteristic ECG changes are seen. Because of the ventricular diastolic dysfunction, the RA becomes dilated and we can see tall peaked P wave, that is P pulmonale, that will be seen in V1, V2 and AVF, and depending on the venous return that is coming to left heart, we will see a ventricular forces on left side. Like here we are seeing minimal left ventricular forces, that means the venous return has significantly gone down, and or it can be the extreme lead placement that has happened, and we are seeing small left ventricular forces in V6, whereas there is a tall R wave in V1. So these are the features of adult VSD pulmonary atresia condition. When adult pulmonary atresia condition, when they start developing systemic hypertension as an acquired heart disease, or there is a because of the renal abnormalities, thromboembolic episode to the renal arteries, they are prone to develop systemic hypertension. Then again, they will have prominent left ventricular forces despite of reduced pulmonary venous return. So these are some of the characteristics that transition happens from childhood to adulthood of pulmonary atresia VSD. X-ray is quite classical in a form that there will be right ventricular apex. Pulmonary bay will be deeply concave. We will not be able to see main pulmonary artery. And depending on the arch, we will see the tracheal indentation either on the right side or the left side. As we all know that 25 to 30% of them will have right-sided aortic arch, and reduced pulmonary vascularity or Lacy pattern. That means irregular vascularity pattern can be seen depending on the collaterals. Where the collaterals are prominent, the hilar shadows are the vascular hilar shadows can become prominent, and differential vascularity is also another hallmark of VSD pulmonary atresia condition. Now, echo is diagnostic. Now, angiography or CT scan is definitely are being done, but they are secondary. First, the diagnosis of choice is the echocardiography. So, like any other tetralogy, large malaligned perimembranous VSD or anterior and cephalide deviation of infundibular septum, that remains the hallmark or monology of VSD pulmonary atresia also. Like in this situation, we are seeing that there is a large malaligned perimembranous VSD with overriding of aorta, and degree of overriding of aorta may vary from case to case. Blindly ending RVOT is another hallmark suggestive that it is a pulmonary atresia. Sometimes in tetralogy of Fallot patients also, when they are quite sick or present to us in a spell condition, we will not see the antegrade flow across right ventricular outflow tract or across the pulmonary valve. Those patients also sometimes are mistaken as VSD pulmonary atresia. So it is better to evaluate them maybe 2 times, or in background of clinical history, that whether patient has suffered increase in cyanosis in last 3-4 hours, he was excessively crying, or whether there was any episode of dehydration, fever episode, because of that the cyanotic spell has aggravated. So all this clinical history should be taken in advance when we are evaluating the right ventricular outflow tract obstruction. Obviously, when we are not seeing main pulmonary artery and only seeing the branch pulmonary artery, that again suggests that it is the VSD pulmonary atresia and not a tetralogy of Fallot baby in a spell condition. It is important to determine, apart from the establishing the diagnosis of VSD pulmonary atresia, it is important to determine the additional things like branch pulmonary arteries, coronary artery abnormalities, sidedness of the arch, and what is the blood supply to the pulmonary arteries. Like in this situation, it is a right-sided aortic arch, and This was a 20 days old baby. We can see that there is an indirect duct which is coming from base of the left innominate artery, a ductus which is severely constricted at the PA end, and likely this baby will deteriorate if we have not given any kind of palliation to him because of the ductal constriction. We will be also able to find out if there are collaterals from the arch view and from descending aorta view. We will see a stealing of blood or extra blood channels which are coming from the descending thoracic aorta and abdominal aorta. If they are very large and supplying proximal pulmonary arteries, then we can see flow reversal from arch of aorta or descending aorta depending on their position. Sometimes they arise from subclavian arteries or carotid arteries. So examining subclavian arteries and neck vessels is also essential in these conditions. Now, apart from this basic evaluation, we have also considered that they are associated with genetic problem like 22q11 deletion. 15% of them can have this Dye-George syndrome, or 5 to 10% of them can associate it with a trisomy, that is 13 and 21. So 13 trisomy, as we all know, is life-threatening, and trisomy 21 is associated with a lot of comorbidities. So it is essential to determine all these things in advance before offering any surgery. So 22q11 deletion is of special importance because it is associated, one, vascular ring, second, they can have calcium deficiency, and third, that they are associated with immunocompromised state. That is, there is a possibility of CD4, T and 8 cell count less than 1000 and less than 800 respectively, making them immunocompromised. If these patients with immunocompromised state are undergoing surgical correction, and if they received a blood transfusion which is immunocompetent T cell, then serious graft versus host reaction can happen because of unable to reject this immunocompetent T cells, and this can become an anaphylactic reaction and can be lethal to baby. So it is important to determine this Dye-George condition in advance, and it is preferable to give them only gamma irradiated blood so that this immunocompetent T cells no more exist in that transfused blood. Not necessarily all Dye-George babies will have immunocompromised state, but it is difficult to determine at one particular condition that the level of CD4, T and 8 cell count. So it is advisable to give gamma irradiated blood to Dye-George babies because there might be variable degree of immunocompetency or immunodeficiency in them. So this is VSD pulmonary atresia is a unique condition because it receives blood supply from various channels. It can be ductus arteriosus, it can be a normal pulmonary artery supplying one particular lung, or it can be a collateral which is solely supplying one particular lobe or one particular segment of the lung. So what happens during primary morphogenesis, the PA circulation changes from foregut blood supply that comes from dorsal aorta to central to pulmonary arteries. We know that the proximal pulmonary artery arises from proximal 6th aortic arch, and the ductus arteriosus arises from distal 6th aortic arch. So this transition from foregut to proximal 6th aortic arch happens if there is an antegrade flow from pulmonary artery or there is a normal formation of the ductus. Then only this transition will take place. That is, the splanchnic plexus, which is coming from dorsal aorta, will regress. If there is no antegrade flow or ductus is not formed because of the pulmonary atresia condition, the splanchnic plexus flow or the flow from the dorsal aorta continues, and that we perceive as a aortopulmonary collaterals once they are born. So in classification, depending on what is the source of blood supply, there are classified by A, B, and C. In A, there is native pulmonary artery which is present, and pulmonary vascular supply is through ductus arteriosus, and there are no aortopulmonary collaterals. So these are ideal subjects for correction and can have good repair. Type B is native pulmonary arteries are present and aortopulmonary collaterals are also present. So we have to tackle these kind of babies because aortopulmonary collaterals after correction can lead to high flow condition and can cause pulmonary edema immediately in postoperative period. So it has to be tackled, and we have to see that which segments they are supplying. Type C is there is no native pulmonary arteries and pulmonary blood supply is happening only through aortopulmonary collaterals. So probably this is the most challenging subset for any palliative or a complete correction. Now, nuclear perfusion scan has also got rule. Depending on the what segment of the lung you are getting supplied, we can plan the surgery, how many segments of the lungs are being supplied. And post-operatively, if there is any pulmonary artery stenosis, then perfusion scan leads us to plan the further management, whether that pulmonary artery needs augmentation or can be left alone so that the somatic growth of the lung can happen. These decisions can be taken by nuclear perfusion scan. Now, as I said, the most important or a challenging part is to evaluate the patency of pulmonary arteries, the amount of pulmonary aortopulmonary collateral which are supplying individual lungs, and the presence of and absence of ductus arteriosus. So over the period of time, various parameters, various indices have come. We all know that Magoon index and Nakata index holds true in tetralogy of Bellot, where there are good size where there are confluent pulmonary arteries. Magoon is actually a distal pre-hilar right pulmonary artery size plus left pulmonary artery size divided by descending aorta, and if it is more than 1.8, it is good for surgical correction. In Nakata index, it's a cross-sectional area of right pulmonary artery plus cross-sectional area of left pulmonary artery divided by body surface area, and it is preferable if it is more than 200. Then obviously LV-RV ratio, the RV-LV ratio will be less, and these patients do well post-operatively. But here in VSD pulmonary atresia, not necessarily that the hilar pulmonary arteries or proximal pulmonary arteries will be present, and not necessarily that they are supplying all segments of the lung. Some segments of the lung are possibly supplied by additional collaterals, and we have to unifocalize them so that after surgery they are getting pulsatile low pressure flow from right pulmonary from right ventricle rather than getting high pressure flow from the systemic circulation. So for these were the fallacies of Nakata index and Magoon index. For that matter, the total neopulmonary artery Z-score has come into consideration. Now what happens, this has been described in 95 by V.M. Reddy et al. So in this condition what happens, we have to take Nakata index as it is, like cross-sectional area of right pulmonary artery and left pulmonary artery, plus we have to add the aortopulmonary indices. Now how do we take this? Aortopulmonary artery cross-sectional area distal to the stenosis, or where desirable site of anastomosis is going to take place. Distal to that area, we have to take this. Suppose there is an aortopulmonary collateral which is very, very stenosed after immediately its origin. Then surgeon would try to do anastomosis distal to that stenosed region so that the aortopulmonary collateral which is connected to the pulmonary artery is without any stenosis. So in this condition, we have to take the cross-sectional area of that particular collateral distal to the steno segment or a desirable place of the anastomosis site. So this we have to add to the Nakata index, and if it comes more than 200 millimeters square divided by meters square, if it comes more than 200, then these patients are going to do well post-operatively. And obviously, Z-scores are now available for left and right pulmonary artery depending on body surface area, which are more reliable than Magoon index. Now these are the things that we have discussed in last slide also, that we have to measure the aortopulmonary collaterals. But I would just emphasize that what are the other things that we need to measure. So number and segments of lung that is being supplied by pulmonary artery, this we need to find out. Second point is number and segment of lung which is being supplied by only MAPCA. This also we need to find out, because these are the segments which are not going to connect to the pulmonary. These are not going to be connected if we only connect pulmonary artery to the systemic venous connection, that is right ventricle, and these segments may become infarcted if collaterals are not connected to the right ventricular circuit. And as I said, stenosis at the lobar level or a segmental level we have to determine and inform surgeon. MAPCA diameter measurement distal to the desired surgical anastomosis point should be taken into consideration. And during measurement, we have to magnify this measurement areas as far as possible so that measurement error is less, and appropriately catheter calibrate it so that the measurement is appropriate. And it is advisable and preferable that two observers take this measurement so that measurement error can come down and we can give a better opinion to surgeons. Now there are quite a lot of confusion exists for the nomenclature of MAPCA when we are describing it to surgeon, like it is direct. We all know that nomenclature exists like it's direct, indirect, or coming from bronchial artery. And some of the nomenclatures exist whether it is communicating, whether it is dual. Other group of nomenclature is whether it is hilar, pre-hilar, segmental, SNR. So there was a lot of confusion in how to label and give advice to a surgeon regarding nomenclature of aortopulmonary collateral. So this was one poster that I got from ACC, and it has been described by Frank Hanley and Stan and Perry group from Stanford group, obviously, that the first nomenclature will be whether it is direct or indirect collateral, suggesting from where it is arising. For example, DTA I have labeled here. Whether it is a single supply or it is a dual supply or it's a mixed supply. That means that particular segment of a lung is supplied by both pulmonary arteries and a collateral, or it is only supplied by a collateral, or it is supplied only by a pulmonary artery. So that will form a second part of the nomenclature. Like here I have mentioned SS, that means it's a single supply. Third is whether there is a additional presence of ductus arteriosus. And fourth is the distribution of aortopulmonary collateral in respect to the segments of the lung. Like here I have mentioned right lung, segment 1, segment 2 and segment 3. So if we state a statement like it's DTA, SS, there are 3, that means the number of collaterals, and that means the segments which are supplied by these collaterals. It will give a brisk information to a reader or an interpreter that how it should be planned in successive cases. So this was brief about the nomenclatures. Some of the thoughts that important before considering the type of surgery in VSD pulmonary atresias. As I said, sometimes the collaterals are communicating. That means a collateral is supplying a proximal part or a hilar part of a pulmonary artery, and a distal segment of the pulmonary artery is supplying, or it is well arborized into those particular segment of the lung. Sometimes they are non-communicating. That means the collateral and a pulmonary artery are not uniformly supplying the same lobe, and pulmonary artery is getting supplied at one particular lobe and collateral is supplying another particular lobe. And in this situation, there are no native pulmonary arteries and all the collaterals, the overall lung vascular bed is being supplied by the collaterals. Sometimes there is a dual supply. Like we can see here, this segment A is supplied by a collateral. We can see here it is supplied by a collateral, and a collateral which is supplying a pulmonary artery is also infiltrating this segment A. So this segment A is good because if we coil or if we close this collateral, still the pulmonary artery patency is there into that particular segment. And when we unifocalize this to right ventricular circuit, it is going to get blood supply from right ventricle. Now look at segment B. Here it is supplied only by pulmonary artery. It is not supplied by any collateral. So again, this is a good segment of a lung because after unifocalization of a pulmonary artery, it will give blood supply to this zone as well. Now look at this zone C. It is not supplying at all by a pulmonary artery. It is solely supplied by a branch of a collateral. Now this segment will not get blood if we have not connected this collateral to pulmonary artery circuit or to right ventricular to PA circuit. After surgery, this segment is going to become infarcted because the sole supply is a collateral. So these considerations has to be taken before sending a patient for surgical correction by CT scan and by angiography, whether there is a dual supply like this, or it is sole supplied by pulmonary artery, or it is only supplied by a collateral. Now this is a histopathology picture of a collateral to suggest that collaterals are not similar to pulmonary artery on histopathologically. Pulmonary arteries have got very thin media so that it can allow the perfusion of oxygen through its wall. But in a collateral, it has got a thick muscular wall, and because of this, it has got tendency to go for stenosis and either can become aneurysm and can rupture. So after correction or after unifocalization also, it may not behave like a pulmonary artery and it's still prone for a rupture or can become stenosed. And again it is different from ductus arteriosus as well, as we know that's because of the thick media. Now after considering this, we are going to some of the palliative procedures. Of course they are palliative because the surgical correction is the most definitive form. Even that requires re-intervention rates. So overall, VSD pulmonary atresia, what we can offer is a palliative surgeries. Now this is one baby, what we have seen the echo, that there was VSD and pulmonary atresia with right aortic arch and indirect ductus. We can see that there is confluent good size branch pulmonary arteries and some stenosis of pulmonary arteries seen at the ductal site insertion. Now since this baby was sick, saturating 60%, and ductus arteriosus is not a reliable source of blood supply to lung bed, it is important to give a reliable source of blood supply to these patients. Once ductus arteriosus is closed, this baby will succumb and can desaturate, can have serious implications because of lack of pulmonary blood flow. So depending on center or institutional policies, some centers believe in ductal stenting, some in PDS stenting because the BT shunt is a high risk procedure. Some centers believe in ductal stenting, like we do oftenly ductal stenting to avoid mortality related to the neonatal BT shunt. Now here the wire is crossed into the right pulmonary artery through the ductus arteriosus, and a stent is positioned. A longer stent is usually required in in indirect ductus so that it will cover the PA end of PDL. So that is the site which commonly undergoes constriction, and if that site is not covered by stent, the stent position is futile. Now after repeated angios that it is in desired position, the stent is inflated, and we can see that it is now good in position, covering the distal end and the proximal end, the aortic end and a PA end, and supplying. There is good flow into both pulmonary arteries seen with good distal arborization. Now, if the stenting or a palliative procedure is done in early in age, the somatic growth of lung will happen and microvascular damage can be minimized. If it is done later on, like 2 or 3 years of age, pulmonary arteries may not grow, the somatic growth of lungs may not happen, and microvascular damage can also ensue. So, in selected subjects, wherever it is possible, doing first stage palliation early in age group is desirable. Now, post-palliation, post-PDA stenting, this can have left pulmonary artery stenosis because duct insert into that site, and as we have said that the PA end, because of the ductal coarctation, LPA is often stenosed. So before sending these patients for further surgical evaluation, we should always do CT scan like we have done here. The right pulmonary artery is quite good in size at 1 year of age. There is left pulmonary artery stenosis, but distal left pulmonary artery is sizable and it can be augmented. So this is a good subset to go ahead for surgery. Nakata index was more than 200, so we expect that the left and right RV and LV ratio will come down post surgery. Now, similar various pictures to confirm that left pulmonary artery is good in size. Now, this is another 12-year-old boy who has good size distal branch pulmonary arteries and a reliable source of blood supply, that there was a collateral which was supplying the left lower area of left pulmonary artery, and there was ductus arteriosus also, like we can see here, which is supplying the proximal pulmonary arteries. Now, whenever we have this additional collateral, we have to make sure that whether it is a sole supply to a particular segment or it is communicating with a pulmonary artery. Suppose it is communicating with a pulmonary artery, we can easily close this off either prior to surgery, or if we think that it is going to be accessible during surgery to surgeon, then even they can offer the closure surgically. It is important to identify all these collaterals prior, because if they have left unnoticed, some of the collaterals will lead to steal phenomena, and during cardiopulmonary bypass, surgeon is going to get lot of returns if it has gone unnoticed. Like in this situation, it is a communicating collateral. It was communicating to left pulmonary artery, so it can be safely ligated intraoperatively prior going to cardiopulmonary bypass, or it can be closed by a plug also, depending on the size. Now this is next baby who is 5 months, presented with a congestive cardiac failure. As I've said that 10% of them can present with congestive cardiac failure if there are large collaterals. Like this situation, there is a collateral which is coming from LMCA and it is supplying proximal pulmonary arteries. The pulmonary arteries are good size for 5-month-old baby with left arborization and right arborizations appear satisfactory. Apart from that, there were multiple other collaterals like we can see here, which is supplying left and right lower lobe. And there is a large collateral which is coming from right subclavian artery. So this is the large collateral which is coming from right subclavian artery. Since there was a source of blood supply from left pulmonary, left main coronary artery, that can happen in less than 10% of population, that a coronary artery gives collateral to pulmonary circulation or pulmonary arteries. The other collaterals can be closed prior to going to surgery. Otherwise, it will be because all this may not be accessible to surgeon while intraoperatively, and it will increase the surgical procedure time as well. So these all collaterals are closed by various plug. That is the one which was coming from the subclavian artery was closed by 8 mm LifeTech vascular plug, and other two collaterals were closed by 5 and 6 mm Amplatzer vascular plug, that generation 4. Now this generation 4 is a very characteristic vascular plug because it can go through diagnostic catheter. It is that is its advantage. It can be manipulated across the stenotic segment of collateral also, because a very small French catheter is required to its delivery. So this is showing that the collateral has been knocked off, and this patient underwent surgical correction, that is VSD closure and RV2PA conduit formation. Now this baby is post ICR who has 3 years of age, 1 year of age. He has undergone ICR surgery, and he had severe left pulmonary artery stenosis, and perfusion scan suggested that the only 9% of perfusion was there on the left side. Now, as we can see in this angio, which is steep aleocranial, that there is a severe stenosis at the origin of left pulmonary artery, and distal right pulmonary artery is well formed. Probably this is a site of ductal insertion. We can see that there is a clip there, the PDA clip there, and that's why the lung and the distal pulmonary artery is well grown. And measurements were done that it is around 11 mm, and length is around 17 mm. Since it was very tight stenosis, just give me a second. This was very tight stenosis. A pre-dilatation with 5×20 Admiral balloon was done, and after that, formula Cook stent was taken of 10×20 size to the desired segment, and after confirming its position, it is inflated. So after inflation, it is 60-40 but well in position, and this is the pictal angio suggesting that there is no significant obstruction to left pulmonary artery with good flow to left segment. Now, since we have done this prior to 4 years of age, we hope that the somatic growth to left lung will happen and the perfusion to left lung will improve. If we are doing after 4 to 5 years of age, the symptomatic status may improve, but somatic growth of that particular lung may not happen. Now, these are the few things that just few slides on hardware that is required to close the collaterals. We can see here this is vascular plug, Amplatzer vascular plug. This is Amplatzer vascular plug 2, which is trilobed, and this is vascular plug 4, which has come recently, and I have shown this one of the pictures. Now, vascular plug 2 is a is multi-layered, multi-lobed nitinol mesh in design, but it requires higher French sheath, maybe 5 to 9 French guide catheter to deploy. And since there are 3 discs and length comes more, sometimes it becomes difficult to occlude, sometimes it becomes difficult to position this kind of devices. This Amplatzer vascular plug 2. Vascular plug 4 is O14 that can be passed through diagnostic 4 French catheter. That is 438-inch diagnostic catheter, 4 or 5 French, and it is made up of O144 nitinol mesh again, and the length becomes more. That is the problem of vascular plug 4, that we can see that the smallest diameter, the unconstrained length can become 10. It can lengthen inside the MAPCA, so we have to well position it, otherwise it can protrude out of the MAPCA depending on the position from where it is coming. So the 8 has got length of 13 mm, whereas unconstrained length of vascular plug 2 is 6, 7, 8, it is less. So that is advantage of vascular plug 2. And vascular plug 4 advantages, it can go through 038 diagnostic catheter, but unconstrained length is more. If it is not well positioned, it can protrude. There are LifeTech or Sera vascular plugs available. Apart from nitinol mesh, there are PTFE patches, so it gives instant embolization and the flow will be blocked very soon. It is available from diameter 4 to 24 and delivery sheath which is required is 4 to 9 French. It has got a rigid and non-flexible delivery sheath, so sometimes manipulating it through the constricted segments of collateral can become difficult. Otherwise, this shape is very much desirable to put into collateral because it will just take a shape of the collateral, and so the shape is good, but the delivery cable is non-rigid. Smaller collaterals can be closed by flipper coils or embolization coils. 4 or 5 French catheters are sufficient to pass them. And if they are not properly positioned, that can be retrieved. That is its advantage. And microcoils are also available. Now, with advancement of fetal echocardiography, we can diagnose this condition and can give appropriate counseling to the family, depending on the pulmonary artery sizes, or if it is a collateral dependent circulation. As we all know that if central pulmonary arteries are not present in VSD pulmonary atresia, then it is not a good subset to go for correction. Like in this situation, this is 20 weeker. Initially, patient had, this fetus has tetralogy fellow, which has progressed to pulmonary atresia. We can see there is a large malaligned perimembranous VSD. And there is an overriding of aorta, that is left ventricle, right ventricle, and overriding of aorta is seen, which is confirmed in color as well. There was aortic and pulmonary artery sizes differences were seen. And here, this is the aortic arch, and you can see that there is a vertical ductus which is coming from arch of aorta. So, central pulmonary arteries were seen in this particular condition. Arteries were seen in this particular substrate, so we can advise family that patient may require conduit or a transannular patch is also sufficient because it has progressed from tetralogy of Fallot to VSD pulmonary atresia. But it is essential to do amniocentesis and rule out genetic abnormalities like trisomies and discharge, and explain family what possible interventions are available with us. We should always explain that re-intervention is required in 15 to 20% of the cases. And after explaining everything, we have to take, we have to give choice to family what is their decision. So in conclusion, it's a complex lesion which requires multiple imaging modalities. Sometimes it requires multiple state surgeries like BT shunt and followed by conduit repair and then reconduit stenosis, LPA-plasty. Some may require LP augmentation during surgery. So it's not a simple disease and require team approach with surgeon, interventional cardiologist, non-invasive interventional cardiologist who is assessing CT scan and echocardiography. And definitely then family and comorbidities if there are any genetic problems. After considering everything, we need to offer surgery and take a call for on patient-to-patient basis. I thank you all for patient listening.